All right, welcome to another podcast. I'm Dr. Nathan Goodyear, and I've got a special guest here for you. Of course, you know him. He's a regular. I work with him. I work for him. That's Dr. Jason Williams. But I wanted to give you some first insight to where we're going with this particular podcast, because, you know, I joined up with the Williams Cancer Institute because of the innovation, the commitment to always bring you the best. And until we bring you the best, we will continue to strive to the best. There's too many people that rest on the laurels of the successes of the past. And let me tell you, at Williams Cancer Institute, that is not the case. In fact, that is something that nobody even talks about. But I have this tradition in my family around Thanksgiving where we always like to watch The Sound of Music on Thanksgiving night. Now, Julie Andrews, she is the star there, obviously, and she was also the star in Mary Poppins. And you may be going, what the heck are you talking about, Dr. Goodyear? I'll get there. There's a very famous quote within Mary Poppins. Now, it's not from Julie Andrews, but it was from her counterpart that said, "Winds in the east, mist coming in, like something is brewing, about to begin. Can't put my finger on what lies in store, but I feel what is to happen all happened before." Now, what I'm talking about is the paradigm shift that Dr. Williams and the team at Williams Cancer Institute, which I'm a proud member of, is bringing. It's the shift of paradigm change that has happened before. It's the winds of change. And the winds of change coming is the approach of intratumoral immunotherapy and intratumoral ablation. Jason, Dr. Williams, welcome again.
Thank you, Nathan. Always good.
Yeah, so obviously everybody knows, I think by now, we went to medical school, we've known each other for a while, and
next to each other, you know, that's an amazing thing, right? I was at tell Stephanie that I was like, we sat right next to each other for this, you know, it wasn't like, you know, that's the class is an auditorium. It wasn't like, you know, you were one side, I was on the other side. Like we actually sat right next to each other.
How many do we have in our class? Like 203 or 100? Okay. Yeah, so obviously. Yeah, I forget. But, we had a good sized class. So here's going to be, now I do want to mention this. Dr. Williams is a published author. Okay. So he's got a great book. I mean, it's great. You need to read it. I've read it twice. The Immunotherapy Revolution. So check it out on Amazon. We're going to put in the show notes the link to it. You can go find it there, and you'll find it a great read, because there's nobody that provides the clinical perspective of the immune system as it relates to cancer. And here we're talking about intratumoral immunotherapy. So there's going to be 4 broad categories here I want to talk about. Basically, just an overview of intratumoral immunotherapy, the paradigm shift. I want to highlight some and show how what we're doing, what Dr. Williams is leading, is the next line. It's that winds of change, the innovation that you'll see at the Williams Cancer Institute, and then the multiple classes of immunotherapeutics. It's not monotherapy. It's multiple therapies. So Jason, you know, it's really interesting because the paradigm that we've been in the last 100 years has been the systemic to tumor approach.
Right.
And from an immunotherapy perspective, that hasn't brought great success. I mean, what do you think about that?
No, yeah. I mean, it's kind of like the idea, like saying you're going to go to a planet and attack a planet, but you really want to attack like one country in the planet, but you're just going to go ahead and just bomb the whole thing, right? I mean, like, you're just going to destroy everybody. And that's kind of what they're doing. I mean, it just makes sense. You got to go to the source. I mean, certainly there's some systemic aspects to it, but, you know, if you're not putting things into the tumor, you're really missing an opportunity. I mean, why not? I mean, we have the capabilities, you know, image guided. We could get needles into tumors. We should be putting medications into tumors. Now, obviously, we know the immunotherapies. I mean, when you want to get the immune system to attack something, you want it to attack in the tumor, right? If you're giving immunotherapy all over your body, where it's going? It's going places that doesn't need to be attacking. So shouldn't you be wanting it in the area that you want it to attack? I mean, that's what the immunotherapy is supposed to be doing. You're giving it, like, you know, it's like saying, okay, we're gonna throw this out there and hope that enough of it gets into the tumor to make a difference. And where putting in the tumor makes, you know, such a big difference, a big impact, because you need it there, and you can use less drug. So that's cost effective. And then also you can use more combinations. So you can use lots of drugs because normally you couldn't use like 8, 9, 10 plus drugs, but with this you can because you're using small doses. So, you use, 5%, 10% dosing maybe, and you're putting it right in the tumor. And that allows you to do lots and lots of drugs. And it's very forgiving, right? Because you're putting it right there in the tumor. You're not going to get these overall systemic problems. So, it makes complete sense.
Yeah, and I like that verbiage, that vocabulary that you use there as it relates to describing bombing the planet to take out a country. It's a war mentality. And when that's that systemic to tumor approach, it falls right into that war mentality. And, when we talk about, trying to achieve, because what's trying to happen here is we're trying to reach the tumor or tumors, because understand so many of our patients, Jason, they have systemic disease, they have huge tumor burden. Mm-hmm. And so we got to reach all these tumors, right? And so the dosing has to be really high to get into the plasma, to get into the extracellular space, to reach the tumor microenvironment, saturate the tumors, the hypoxia, the normoxic areas, all of it. And basically what that does is it turns the body into the collateral damage. Like you said, you're trying to take out one thing and you just end up taking everything out.
Yeah.
As a result. But, remember when I came down to Cabo and I interviewed you on the old podcast, I asked you, I said, well, why go to the tumor? And you said, well, I want to ask you a question. Why would you go systemic? And you turned that question around on me and challenged me. And I was going, well, that kind of makes sense. But when you start to understand the impact of the immune system, just looking at systemic immunotherapy, we start to see that, because it's really interesting, Jason, when you look at the literature. I mean, I ran across a 2018 study that said an estimated 43.6% of cancer patients are eligible for immunotherapy, meaning it's approved. Yet the ranges vary. It's very clear, but several studies have said the range is around 12.46% or 15 to 20% across a multitude of studies. So systemic immunotherapy, it's not very effective.
Yeah. Yeah. And, and I think the thing is, you see all this like in the animal studies, these animal studies where they injected these drugs in the tumors and they work amazingly well. I mean, I think Jim Allison, who won the Nobel Prize for, CTLA-4 and Yervoy, they did studies with, injecting in the tumors and numerous other groups. I mean, I've just got, Levy at Stanford, and all these guys showing that, okay, when we inject in the tumor, it works way better. And they show it in comparison. Okay, if we take that same drug, Opdivo, Keytruda, Yervoy, inject in the tumor versus injecting it into a vein, the effects are dramatically different. And so, that just makes complete sense to be putting these drugs in the tumor.
Well, and you're an interventional radiologist, so it's kind of right up your alley. And I've had you do this over and over again. I think we were in our third year or fourth year of medical schools. You mentioned a story where you were somewhere and they had a needle in a tumor, and you asked, well, why can't we treat it? I think they were doing a biopsy or something.
Well, what happened was that, initially when before I went to medical school, I was doing, research, and we were doing these therapies and we were injecting into tumors. And then, when we, we're seeing good results, but then they take the same drug and then they give it systemically. And I was like, well, that makes no sense, because we were injecting into the tumors and it worked really well. And, that was the thing, is that they said, well, no, it's just too hard to inject it into tumors. And then, when we had our interventional radiology lectures and at LSU there, they, were saying, hey, well, we're sticking needles in the tumors, doing biopsies. Like, oh, well, yeah, if you can stick a needle in a tumor, can you inject? And that was the question. And clearly you can. I mean, if you're going to take the time to biopsy something, you could take the time to treat it. You could stick, you're sticking a needle in it. So you could do that. And so.
And, and you're talking about it from a treatment perspective, but I think you could also look at it and say, well, though the risk associated with a biopsy in terms of reseeding or seeding the local tract or even spreading, it seems to me that you should, if you're going to do a biopsy, you should provide some local treatment. to really prevent that issue. Because, and you've seen this, I can't tell you how many times biopsies I've seen where there's been local recurrence, local reseeding in that location. I mean, just spot, right in the same spot. And there's all kinds of animal studies that have shown this. Though it's a low risk, it's still a very real risk.
Yeah, I mean, I think the thing is that, if you're going to biopsy something, you should probably be treating it at the same time. You shouldn't biopsy and then leave, and then you flared it all up and made it now want to get aggressive, because that's what happens. We need to biopsy and treat at that same time. That should be the future.
It's the future that is really...
We're doing it, right?
Let's say.
If we have...
That's the thing. Go ahead.
Yeah, if a patient comes to us, if somebody came to me and said, hey, I've been diagnosed with a mass, we don't know what it is. Oh, that's perfect, right? We're going to go ahead. We're going to treat it. We're going to diagnose it. We're going to do it all at the same time. Don't, not mess around.
That's what when I talk to the patients, Jason, I tell them, I said, look, you don't have to hope for the future. You don't have to think about the future. You don't have to, expect it. You get it at the Williams. And that's not hyperbole. It really is not. And so that's a good tie-in, because when you look at some of these major delivery techniques in medicine, there have been some major paradigm shifts. So what I want to do here, Jason, is kind of highlight those. And I really want to put, the innovation that you provided at the end, because I think it's very appropriate. So first, is the germ theory of disease in the 19th century, when, they moved away from the miasma theory, which is the concept that there were these foul smelling, bad air, things that were causing disease, and actually said, no, there's actually, infectious causes here, bacteria, viruses at that point. So then we move on to the 20th century. We've got antibiotics and chemotherapy. Paul Ehrlich brought forth the first concept of the magic bullet theory, which is chemotherapy. One disease, one treatment. And I want to talk about that in a second, Jason, because I think in the intratumoral immunotherapy approach, where others are starting to do that, they're falling trapped to that same concept. Mm-hmm. And up your alley, the development of imaging techniques like X-rays, CTs, MRIs, PET scans, which we make use of, and the value they provide in diagnostics and therapeutics. The move to minimally invasive, less cutting, less recovery, less damage, and minimizing that to preserve organs. And we've talked a lot about that, and I want to touch on that with you as well. The risk of the rise of genomic mutations, so precision, of course, I want to talk to you about that. And then immunotherapy in the 21st century, so all of those were 20th except for the miasma moved back to infection. And now we get into immunotherapy, but really, what you have led, and what the Williams Cancer Institute as a whole is leading, is that next step of immunotherapy to intratumoral therapy, but immunotherapy. And so, again, I don't say this as hyperbole. I really see this as a paradigm change that history will look at and will say, wow, that is crazy innovative thinking. Yet for you, it was you were just sitting there going, what? I did it in animals before, and you're putting a needle in. Why can't we?
Yeah. I mean, it just seems, I don't know, it seems so obvious that I can't believe that people are so resistant. I mean, that the mainstream medical and oncologists are so resistant to the idea that you need to go attack the tumor directly with these drugs. Oh, and it makes sense.
Well, and I was talking with Aaron behind the scenes, and he was talking about, Nobel Prizes and stuff like that. I said, well, the Nobel Prize here is actually the approach. It's the intratumoral, it's the changing of the process. So, hey, hello, Nobel Prize in Medicine and Physiology. If you don't know Dr. Williams and the Williams Cancer Institute, you should. So if you're watching this, share it to them, because let me tell you what, this is the technology. This is the innovation that I think is what brings those kind of awards. And honestly, Jason, you should be up there, because I didn't create that timeline because I thought it was just something neat. I think it's real. And we see it in our patients too.
Yeah.
I mean, goodness gracious, we see it in our patients.
Yeah, so, obviously we're, doing all our studies and clinical trials and various things, and we'll have different publications, and so we're getting stuff out that will help, get this and talking to lots of people. I had great meetings with, people at LSU and trying to develop a program there, talking to people out in LA, trying to get a, program going there, trying to get everybody into this concept of this, intratumoral immunotherapy, or, it's interventional oncology is what, you kind of consider it. It doesn't have like the official, specialty, right? It's like radiologists kind of have it. The oncologists aren't really in it, but the oncologists need to be in it. And that's one of the things that we're kind of saying, is that oncology should become a field that they simultaneously work, and study radiology, just like the cardiologists did, and, and become proficient in being able to do procedures. And, that's what the oncologist will need to do as well. I mean, that's the oncology needs to be, especially where they're sticking needles in the tumors.
And one of the, so the idea of just, stick a needle in it, let's treat it. But then there seems to be, and again, medicine just falls prey to this, magic bullet theory. Do one thing. Paul Urick, it's the brilliance that you brought, but it's a little bit of a chain in thought that you've held on our necks. But when you look at the literature about intratumoral therapy, there's intratumoral ablation, and then there's intratumoral immunotherapy. And it doesn't really seem like they're combining them at all.
No.
And that to me seems to be a big downside, a big miss on their part. But that's where I think what you came up with and what you really innovative and brought forth was that, goodness gracious, if we destroy cancer, create new antigens, we need to provide the immunotherapy activation at the same time.
Yeah. You're in there with a needle. You got the great opportunity, right? If you're going to do ablation, and lots of ablations are done, cryo, obviously, radio frequency. We know that it seems like pulse electrical field, probably the more immune stimulating consistently. Cryoablation can be in a certain degree, but you have to be cautious. Again, there's certain techniques of how you do this. It's not like you just go blast everything. I mean, unfortunately, when people are doing ablations, they have the idea, just ablate everything, destroy it all, and destroy some normal tissue. And that might not be the best if you're looking for an immune response. But you want to just destroy a little bit of cancer, give the immune system that stuff, the information. But, it's that you're there, you got that opportunity. It's like, it's so missed. I mean, they're sticking these needles in there and they're not injecting the drugs. If they're injecting the drugs at the same time, then that would be great treatment. And so, it's really unfortunate.
Yeah. And that's where, when you look at, the abscopal effect, which is what we're really taking advantage of, which is the harnessing and the training of the immune system locally, and then that immune activation that gets harnessed and transferred systemically. And that was originally described in the radiation literature. But, with radiation, most cases, they're going in there to, ablate the whole tumor. And so It's destroying everything. And I love what you said when we were on that phone call or that Zoom with that patient one time, and the doctor was trying to say, well, what about cryo? What about cryo? And you had to step in and say, look, I've done more cryo than anybody in the world.
Yeah.
And so I've switched because, this pulse electric field therapy provides a more immunostimulatory, ablative technique.
Yeah, I think the thing that's nice with PF is that that you just do small volumes, so even with like the untrained, unskilled doctor, it makes it hard for them to do too much because it would be very cumbersome because you can only do small ablations. And so, but that's really all you need to do. You only need to do a few, and another thing is that, we know, but the other doctors don't know this. So you look at a tumor, the tumor's actually heterogeneous. And so I can see this part of the tumor. I want to ablate that. I want to ablate that area of the nidus. The other doctors won't see that, but in the future, we're trying to develop, techniques and technology that will help assist them to know that. But yeah, there's parts of the tumor that may be more resistant that you would target. you can see it on the imaging. And so, yeah, these are techniques that we're working on, and it's going to improve all the immune responses by hitting these resistant areas in the tumor. And yeah, if you go through and blast everything, and particularly start damaging normal tissue, which is what a lot of times they do. They're looking like, oh, there's a cancer there. I need to eradicate all. I need to just blow the whole thing up. But when they damage that normal tissue, you end up getting, surges of other growth factors, TGF-beta, and other things as well, and that will suppress the immune response potentially. And so you may actually shoot yourself in the foot by doing that, by thinking that you're getting all the cancer, and yet not necessarily that's the best thing. I mean, maybe you just want to kill some cancer to start the immune response.
And that's one of the things I think that when people are talking about intratumoral immunotherapy or ablation, they think that we're just sticking a needle anywhere. Right? There's a tumor, 8 centimeter tumor, just stick it right in the middle.
You're doing that. You're
very precise. But you're targeting a very specific part of a very specific tumor. I mean, that's one of the things that I think people miss. And you always send me some really interesting cases from time to time where you're actually doing this in real time, CT guided or ultrasound guided, and you follow the needle into the tumor, assure you're in the right spot. That's when you ablate. Then that's when you do the intratumoral therapy. Creates the magic sauce. So it's one stick and you're out.
Yeah. I mean, you want to select the areas in tumors. That's the thing, is that unfortunately, I'm sure anybody else that's doing ablation is just get the needle in the tumor, right? They don't really precisely look at areas where we're much more, looking at what areas of tumor. It's just different. It's a different process. So we try to get the doctors to think this way, to understand that, look, there's areas of tumor you want to ablate. You don't want to ablate the whole thing, and then just try to change that mindset.
So in that light, because we've already talked about PEF before, so if you want to check out that podcast, definitely go check that out. You can find it at pre-scribe.com. You'll find it on Williams Cancer Institute's YouTube. So you can find it everywhere where we dive deep into PEF. But so in that light of targeting very specific aspect of the tumor, likewise with intratumoral immunotherapy, there can be precision targeting there as well. So for example, we see tons of patients with pancreatic cancer, and clearly, research shows that the number one just about, genomic mutation in that pancreatic cancer is KRAS G12D.
Yeah.
We target that.
Yeah, there's drugs that will target KRAS mutations, and that will also, fix that, but it affects the immune response. And so those are ways to do that. And so you want to, when it's appropriate, you definitely want to take that. And that's why you got to do lots of agents on these. I mean, there's no way you're not going to get this 1, 2, even 3. I mean, you're going to need multiple agents,